So I want to welcome you all to our fall community seminar, our fall Levy community seminar. I'm Chris Rebelo. I'm the Director of Communications here at the Buck Institute, and I'll be moderating today's event. First of all, the first thing, congratulations for getting in the door. Seriously. This event was sold out 2 days after we posted it. We've gotten lots of phone calls from folks who wanted to get in, so really, those of you who registered early, it really is an example of the early bird catches the worm, so congrats for being here. Housekeeping issues, I need to point out a couple things. There are exits at the back of the room, so should disaster befall us in the next 90 minutes, head for the back of the room. And also, I'm asking that you turn off your cell phones. Not only out of courtesy, but the fact that sometimes the signals interrupt our sound system here, so we want to have the sound be as clean as possible. And I don't want to forget our thank yous. We have staff members, our speakers, and volunteers who have all donated their time to help us put on this event today, so thanks to them. And also I want to thank Novato Public Television, the community television station. They're videotaping today's event, so it will be online. And so if there's something from today's event that you want to go back and review, you'll be able to do that. The reason that we're all here today is because of the generosity of the Levy family. Mrs. Levy has funded a community seminar for 12 years. So we really do want to thank her. Yes. So these events are done in honor of Dr. S. William Levy, who was a renowned dermatologist in both San Francisco and Marin County, as well as a clinical professor at UCSF, a published author, and an international lecturer. In addition to having a great sense of humor, as you can see from this photo, Dr. Levy was also a visionary. He was an advisor to the Buck Institute and a supporter starting in 1993. That was 6 years before this building opened. So he was instrumental in helping the founders really plot a course for the Institute. Mrs. Levy remains a key supporter of our efforts to help all of us live better, longer. Mrs. Levy, I want you to stand up and take a bow. I also want to point out that Mr. Levy's brother is also here today. He's 101 years old. He got here by himself today. Pretty cool, huh? All right. So our hope is that all of you who are here today are inspired by Mrs. Levy's generosity and are moved to support our research here at the Buck. Given the overwhelming interest in today's seminar, there's no doubt in our minds that all of us are eager for information that's going to help us enjoy being older adults. Here at the Buck, we want the information that we provide to you to be based on science. And that's where you come in. We're asking you to support the research that happens here at the Buck. There is a donation flyer in your packet. Our goal is to have aging without illness to prevent and treat age-related diseases. If you have any questions about any of our research programs, believe me, I'd be happy to talk to you after today's event. If you're new to the Buck, one of the best ways to get involved is to become a Buck member. If you like today's event, I will guarantee that you're going to love being a Buck member. And there is no better time to join than now, because if you join, you'll be eligible to come to our exclusive member event on November 14th. I will be in conversation with Dr. Pankaj Kapahi, one of our faculty, who is doing really exciting work on nutrition, metabolism, and aging. So he has the biggest lab at the Buck. There's lots of interesting projects on diabetes and circadian rhythms and gut health. So there's something for everybody. I really do encourage you to become a member. There's a member table out in the atrium. There's also this handout that reminds you about this event. So for this event, this is how we're going to proceed. After you hear from our speakers, there will be time for your questions. Each of you got a little white index card in your packet. We're asking you to write your questions down. We'll have volunteers who are going to pick up those questions and give them to me. So that's how that's going to work. We'll be ready to hand out more cards and more pencils if you need them. And just a gentle reminder, as thrilled as we are to have two MDs here in the room today, I want to remind you that this is not an office visit. So please try to ask questions that would be of interest to the general crowd. And finally, we're going to have some handouts from this event that cover some of the key points. Those handouts will be available as you exit the Drexler. So now it is my pleasure to introduce the Buck's president and CEO, Dr. Eric Verdin. This is Eric's first community seminar himself. So he came to the Buck last November, so he missed the last Levy Community Seminar, so we're thrilled that he's able to be here today. He's going to introduce our speakers, and he's also just going to give us a talk for a few minutes about his vision for the Buck Institute. Eric, it's all yours.
Thank you, Chris. Good morning, everybody. Welcome to the Buck Institute. I think this is a really exciting event for me, and I suspect for all of you. I want to start by acknowledging Mrs. Levy for her support. I think this type of event and meeting is exactly what the Buck, I think, should be. And this is under my leadership. This is the direction in which we will be amplifying our effort. I think there could not be a better topic today in terms of this seminar being focused on geriatricians, talking to the community, because this is exactly the directions in which I want to take this institute. So I came here last November after a 20-year career at UCSF, running a research lab, and took the helm of this institution last November. And I could not be more excited by where we are today with the Buck Institute and what lies in the future. So we are at an inflection point in terms of aging research, and you might not be aware, but you might have seen lots of stories in the press about living older, living better. I also want to celebrate Mr. Levy. I think at 101, and in the shape you are, I think you are exactly the inspiration towards which we are striving. This is exactly what we're thinking about. We're not talking about making people live to 200 or 400. This is pure fantasy. We're talking about living better, longer, living healthy, being active in your community, participating and enjoying your later years of life. So this is what the Buck is all about. Now, how will we do this? We are, as I said, we are at a critical point in the history of aging research. Picture yourself back 30 years ago. In biology, aging was thought as a problem that could not be solved and could not even be studied, because it was thought as a sort of everything falls apart in some random way as you age, and there's nothing you can do about. But a number of key discoveries were made in the late 80s, early 90s that completely changed the way we think about aging. And these discoveries were the fact that there are genes and proteins in our bodies that control the aging process. And not only do they do this, but by controlling aging, they control our susceptibility to a whole series of diseases that we now call the chronic diseases of aging. So these are a group of diseases that you're all familiar with: Alzheimer's disease, Parkinson's disease, macular degeneration, heart attacks, stroke, many forms of cancers, their main risk factor is how old you get. And so no one really ever understood this. And this research at the Buck has allowed us to demonstrate for the first time that aging itself is what drives these diseases. So the focus of our work is on understanding what is aging, can we modify it, with the hope that by modifying the aging process, we will affect all of these diseases at once and allow people to live longer, better. So I could not be more excited by where we are today and the directions that the Institute is taking, which will be really taking all of this basic knowledge that we've accumulated for now 20 years. So the Buck was the first research aging institute, and we've accumulated a lot of knowledge about what constitutes aging. We now have drugs that we can actually use to interfere with the aging process. We're also studying the effect of exercise, of nutrition, and so on. And our focus in the next 20 years will be really to take all of this knowledge and start translating it into patients, and so that we can make people live better longer. So this transition will include an increased focus on the chronic diseases of aging. It will also possibly include the building of a clinical center here at the Buck, which actually could serve as a geriatric clinic, provided that we are able to raise all the support that will be necessary for this. This will be the future of the Buck. So if you yourself or know of someone who has the means to help us in building this vision, again, like Chris said, contact us afterwards. I think this is really, we're going to need a lot of support to make this vision a reality. So again, going back to our program today, I could not be more excited to have the two speakers that we have. They really represent the future of the Buck. The first speaker is John Newman, who is an MD PhD, so a physician scientist. He obtained both of his degrees from the University of Washington and then conducted his clinical training at UCSF. He's also a member of my lab where he does research. And his research has focused on understanding what is it about nutrition and how you eat that can affect your longevity. This is one of the strongest variables that can determine your longevity. How well do you eat? How much do you eat? And John actually had a very sort of public splash last week. He published a paper on a ketogenic diet. We have actually gotten a lot of press on this story, and there's a flyer outside. If you want to read it, you will hear what John does really specifically in the lab. As I said, John is a physician scientist, so he does not only research, basic research, but also sees patients at the VA hospital in San Francisco. He also teaches medical students, and he's a geriatrician. And I know you're in for a treat. He's a great speaker, and we will enjoy what he has to tell us about this transition. Our second speaker is Victoria Tang, who's also from UCSF. She has obtained her degree from UT Southwestern in Dallas and some clinical training at UCSF. And she specializes in a really unique aspect of geriatrics, both in terms of her research and in terms of her clinical work, which is so surgery is a significant risk factor the older you get. And so she's trying to understand what is it about the aged populations in terms of their risk during surgery, and how can we mitigate these risks and actually make surgery less stressful on an older body and more successful ultimately. So without further ado, I think I want to welcome John to the podium, and thank you very much for coming again, and I look forward to seeing you next year.
Yeah, welcome with you. Thanks.
Hi, everyone. Thanks for coming. It's wonderful to see you all here. So I'm Dr. Newman. I'm a geriatrician.
I'm Dr. Tang. I'm also a geriatrician.
And today we're going to teach you how to be your own geriatrician, or at least a little bit. Let's call up my slides here. So when you're a doctor and you're out in public and just doing your thing, and like Dr. Tang and I this morning were looking over our slides as we were having some coffee in Novato, and people come up to you when they hear you're a doctor, or you meet some stranger and introduce yourself, and you get the strangest questions sometimes. It's amazing what people will just out and ask you just because you're a doctor. I can imagine, if you're a dermatologist and someone hears you're a dermatologist, oh, hey, I got this thing. So this morning as we were having coffee, the person at the table next to us, I think, overheard us saying that we're doctors and we're geriatricians, and then grabbed us as we were walking out. And excuse me, did I overhear you? Are you doctors? Could I ask you a question? Sure. What was that sunscreen you were using?
Using the sunscreen.
That wasn't the strangest question I've gotten as a geriatrician. The most common question I think we get when we introduce ourselves as geriatricians is actually, geriatrics, what's that?
I get a lot of, are you a nutritionist?
So let's start there. Who knows what a geriatrician is? What geriatricians do?
Wow.
That's
really
a lot of you. Fantastic. I think this is a bit of a self-selected audience. I saw a lot of people without their hands up, though, so you're here for good reason, too. So we thought we'd start there and just tell you a little bit about who are geriatricians, what do we do, where do we come from, and then there are two goals, I think, of the next hour or so. We're going to talk about goals a lot. The first goal is to teach you a little bit about how we think and how that's different from how many other doctors think. And the other goal is to let you leave here with some kind of concrete tips on how to talk to your doctor, how to think about your own medical care, and how to talk with your family and friends about your medical care. So who are geriatricians? We'll start there real quick. So we are medical subspecialists. So Dr. Tang and I both started in internal medicine. Mm-hmm. So first we trained as internists, and then we do subspecialty training in a fellowship in geriatric medicine. So much like cardiologists are subspecialists for the heart, or pulmonologists are subspecialists for the lungs, we're also medical subspecialists. But we're a little different. We're not subspecialists for an organ or a system. We like to say that we are the subspecialists that specialize in how to care for older adults. We're actually subspecialists for people, and that's different than most medical subspecialists. And that's gonna be one of the big themes that we talk about today, how that makes the way that we think different from the way that, say, a neurologist or cardiologist or pulmonologist or a gastroenterologist or a podiatrist or so on and so on think. So who is geriatric? This is another question we get a lot. Oh, so you're a geriatrician. Am I geriatric? So I won't ask you to raise your hands, but I'm going to guess that if I did ask you who here thinks they're geriatric, most of you are going to say, not me, but that person might be.
I am.
So who do we care for? Who do we kind of specialize in? Well, we'll talk more about this, but in general, we focus the most on older people, yes, but age is not a number. It's not just how old you are, but it's how functional you are. So we focus the most on people who are the most complicated, the people who have lots of medical problems going on, the people who maybe need help doing things day to day. Often we take care of people with cognitive impairment or with dementia. We take care of people with complicated social situations, complicated caregiving situations. The more complicated and more complicated person you are, the more excited we are to meet you and hear your life story.
It's true.
Which is also a little different from most doctors. But that's a theme we're going to come back to again and again too. We love complexity. We thrive on complexity, and sometimes we actually call ourselves complexivists. So we are the doctors who really focus on how to drill through that complexity and figure out how to help you as a person. I'll talk a little more later about where you can find us or why it's so hard to find us. But so we are doctors. One of the main themes we'll talk about all through the next hour is about goals. We think a lot about what is the big picture. What are we really trying to accomplish with this or with that? What is the most important thing to you? What's the most important thing to me? What are our goals? We're doctors that treat the whole person. And complexity. We love complexity because many of you guys have probably experienced this, and we'll use falls as an example to illustrate this later. But there's never just one cause. It's never just one thing. It's always lots of things that all come together to cause something that affects the way you live your life, or makes it so it's harder for you to do something you want to do. It's always more than one thing, and they all interact with each other. But we love sorting through that complexity. So here's my next question. So those of you who knew what a geriatrician was, how many of you have actually seen a geriatrician in a medical setting? Oh my.
Wow.
As a patient. So it doesn't count if your son or grandson or granddaughter is one. I think I saw 2 hands and they didn't even look too sure of themselves. So that's not uncommon. On the one hand, we are everywhere. So we are,
Yes.
keep coming back to this theme, we're doctors for people rather than an organ or a setting. So you will find geriatricians everywhere where older adults get medical care. So some of us do house calls. That's actually still a thing in some places, and it's becoming more common. Many of us do primary care in the clinic, where we are the main day-to-day doctor for people. Some of us do consulting, where we give advice to other doctors. We take care of people in the hospital, both as their primary doctors and as consultants. We take care of people in the intensive care unit even. We take care of people in nursing homes. We see people before surgery. We see people after surgery. Wherever older people get medical care, geriatricians are there. But we're awfully hard to find, even though we're kind of everywhere and nowhere at the same time, because there's very few of us. There's a variety of reasons for this, but when it comes down to it, there's not nearly enough of us to actually do hands-on care for everyone who might benefit from that. There's, depending on how you count, one way or the other, there's probably somewhere on the order of about 5,000 geriatricians in the entire country. There's about 50 million people right now who are over 65. Not all of them need geriatricians, but many of them do. And even just thinking about the most frail, the ones who need us the most, there's still not enough of us to go around. So that's why a lot of us spend our time not just taking care of people hands-on, although we're all doing this because we love that. But we spend a lot of our time figuring out how to make the entire healthcare system work better for older adults. So a lot of geriatricians spend a lot of time doing research, not just into how to treat older adults, but how to change this entire system of care, how to change the way a hospital works, how to change the way primary care works, how to change the way clinics work, how to change the way that health insurance works, how to change the way that national healthcare systems work to make them work better for older adults. Because we can't do everything ourselves. We want to set up the entire system if we can to make it work better for older adults. And we spend a lot of time teaching. We spend a lot of time teaching medical students, teaching residents, because most of the doctors that are going to see older adults are not going to be geriatricians, but most doctors will wind up most of their patients being older adults. So we'd like to teach them the principles of how to do a better job of taking care of their older adults. So we do a lot of teaching, we do a lot of research, we do a lot of behind the scenes trying to make things work better. We're sort of like the secret agents of medicine. We try to infiltrate ourselves everywhere we can to make the entire system work better for older adults. So.
Okay, great. Yeah. So the one thing that I would add, sorry, I'm going to take this pointer from you. So the one thing that I would add to Dr. Newman's pointing out that we're everywhere but we're nowhere is that we recognize that there aren't enough of us geriatricians, but the population is aging and we really care and want to make sure the health system is ready and providing the good quality care that older adults need. So along with the things that John listed, there are other things like health policy that we're working on. We sit on national committees to try and do that. And a lot of our folks at UCSF aren't just clinicians, they see it as their mission. We see it as our mission to change the system. So the three things that we're going to cover today, these concepts, are individualizing care, which will focus a lot about goals, geriatric syndromes, which gets around that complexity that we were talking about, and then also covering important conversations. Is John okay, great, Thanks. So when I do this, you'll, great. So the first section that we'll talk about is individualizing care. And what do I mean by that? So individualizing care requires really understanding who we're treating, who is this person. So we need to understand that older adults are not the same as 25-year-olds, and 25-year-olds are not the same as children, right? We can all kind of see that, and they need different things. And so with individualizing care, we actually look at that person and say, what do they need, and how can we tailor our care to them? Thanks. Usual medical care works like this. It's kind of cookbook medicine. You go to the guidelines, you say, Mrs. So-and-so has this, high blood pressure, they have diabetes. These are the things that we need to do to treat her diseases. So in the early 2000s, this geriatrician, who's also a researcher, published this really seminal paper. Didn't even do any research. It wasn't even research related. It was basically her taking all the guidelines that our medical societies say need to happen for an older adult given these diseases that they have. And so this is an example of a 79-year-old woman who has high blood pressure, type 2 diabetes, osteoporosis, and some chronic obstructive pulmonary disease. So just, 4 things, still very functional, no other kind of medical comorbidities. And this is what it would look like for her if they followed all the guidelines. So at 7 a.m., she has to do her inhalers, she has to do her osteoporosis medication. Also, check her feet, make sure she's sitting upright because that osteoporosis medication can cause issues otherwise. Also to check her blood pressure. 8 a.m., a whole slew of medications. This is her vitamins, this is her blood pressure medications, her diabetes medications, and some other pain medications. And then here's her diet, right? Eat breakfast, low sodium, low potassium, low fat, low cholesterol, but make sure you have your magnesium and calcium, okay? And make sure it's a diabetic diet. So that's her morning. And then at 12 p.m., make sure she keeps the same diet. And this is all just in the morning. Thank you. So then in the afternoon, 1 p.m., doing her inhalers again, some more vitamins, and then 7 p.m. inhalers, more medications, some diabetes medications, and then the same diet. 11 p.m. inhalers, and then as needed, some more inhalers. So you can see this picture of this woman, and I'm sure some of you in the audience have this kind of routine, right? You get up and the first thing you think about, I gotta make sure I take my medications, I gotta do it this way, and then in lunchtime and at dinner. So it can be pretty intensive, thank you, I'll give you that, of a lifestyle. So for her, this 79-year-old with only 4 medical conditions has 12 medications, 19 doses at 5 different time points every day. Does that make sense? Maybe for her, she can handle that. That's her decision. That's what she wants to do. But really, just taking a step back and saying, why are we doing this? What is going on? Does this actually fit with what her goals are? And so one of the kind of key take-home messages that we want to give you guys is to not treat the diseases, but push to treat the person, to make sure to understand what your goals are and to share that with your healthcare providers, with your family, and to not get into this cookbook medicine of the guidelines say to do this, I'm gonna do this, and now my whole life revolves around my healthcare and I've got to go to 20 million, clinic visits, right? Multiple doctors. So I wanted to share an example of individualizing care for big picture goals. So this is one of my patients that I saw in my geriatric surgery clinic at UCSF. So this is Mr. D. He's 85. He's got some mild cognitive impairment, some high blood pressure, diabetes, otherwise functioning well, lives in Hawaii half the time, lives in California with his family the other half. And so Mr. D had actually this issue in which he had a mass here obstructing the flow of bile in his gallbladder to his small intestine. And because this mass was here and obstructing, he would get these recurrent infections of his gallbladder. Because of these infections, he would have to go in and out of the hospital, and during that time, he would just lay in bed and basically start losing his function. He'd not only lose his function, he wasn't able to eat, right? And so because of that, he was malnutritioned, not able to function the way that he wanted to, and, asking him, hey, what are we doing? What's all this about? What's important to you? And so Mr. D tells us, I just really want to spend time with my grandkids. I don't really care about how much longer or how much shorter I have to live, but I want to spend it good quality life, hang out with my grandkids for the best ability that I can. And so that's what's important to him. And so we, weighed the options. We said, surgery to remove this, gallbladder and rewire things so that he would not have that mass. That's a high-risk surgery. There could be tons of complications. You can end up in the nursing home or, not do well afterwards. He said that's fine because this going into the hospital, going out of the hospital, not being able to eat, that's not helping him get to his goals. At least the other option would. And so we supported that. We didn't say, hey, you're 85, you have these issues, we're not gonna do it because it's high risk. We said, what is your goal? We will help you achieve them, or at least try, right? So again, basically what we want you to get is we want to treat the people, not just the disease, and individualizing care for the big picture goals is what we want, not addressing these small diseases and letting it kind of overtake your life. Okay, thank you.
And I want to emphasize that we often talk about doing more or doing less, but it's not really about doing more or doing less. It's about doing what's right to help reach the goals that you've set together with your team. And sometimes, like in that case, it means doing something that's a little more dangerous because that's the best chance that he has to reach the goals that are most important to him. Sometimes, though, it is about doing a little bit less and trying to avoid those harms to keep someone going as best they can as long as possible. But it's not about more or less, it's about doing what's right to reach the goals. So next we'll talk about geriatric syndromes. So I said that geriatricians are doctors for older adults. We're doctors for people. We're not heart doctors or lung doctors. We're everything doctors. But if there is something that we really specialize in, it's in these things called geriatric syndromes. Falls are an example of this. Falls are a terrible problem, as many of you know. I won't ask you to raise your hands to know who's had a family member had a bad fall or who has themselves. But falls are extremely common. They're one of the leading causes of people becoming disabled and losing their mobility and needing surgery, and they're a terrible thing. What's even worse about falls is there's something it's very easy to be scared of, but even being afraid of falls can actually make it more likely that you'll fall. So falls are terrible. Why do people fall? It's, when you ask someone, they come into the emergency room afterwards, what happened? Well, maybe I tripped on that rug, or I tripped walking over the curb. But it's not the curb, really, and it's not the rug, really. It's usually a lot of different things all together that contributed to that fall. It's never just one thing alone. And think about, all of the different things that have to go right for us to just be able to walk and put one foot in front of the other and maintain our balance and see the floor and see what we need to step over and know where our feet are. All the things that have to go right just to walk. And while I'm saying that, I'm being very careful not to fall over the edge of the stage and make this a hands-on demonstration. And all those things can be affected by processes that happen as we age, normal changes that happen to everyone, as well as by diseases that we tend to accumulate as we get older and older. And usually a fall is contributed to by many of these different things. It's a little bit of the weakness. It's a little bit of the arthritis and the pain in the knee. It's a little bit of the dizziness that maybe a medication was causing. Maybe it's a little bit of the urinary urgency that water pill was making, and a person had to get up a little too fast. But it's all these things together that contribute to a fall. So a fall is an example of a geriatric syndrome. These are very common conditions that can have very large impacts on people's lives, affecting their independence and their mobility. But they always have more than one cause. They have multiple causes coming from multiple systems throughout the body. Other examples of geriatric syndromes are dementia or cognitive decline, frailty, incontinence, and delirium, an acute confusional state that's very common in the hospital. So these are geriatric syndromes. How do you even begin to treat something like this? Well, we have a system. We have a system that we've developed through years and years of research and randomized trials. So part of that system is taking a systematic head-to-toe approach of identifying all the different risk factors that may have contributed to something like this. So, a little bit of the balance, a little bit of the weakness, a little bit of the arthritis. And then you develop a comprehensive assessment and a multi-component or multifactorial intervention to whack all the things that seem like they're the most important contributors to the syndrome, like the fall. You're not trying to fix everything, but part of the art and science of this is trying to figure out what are the most important things, focusing on them, and if you can fix enough of them, you'll change the big outcome. You'll prevent the falls. And we know that this kind of approach works in large randomized trials that have studied kind of systematic protocolized versions of this. So it's a little more sophisticated than a whack-a-mole, but that's the general idea. And we can't do this alone. So one of the things that all geriatricians have in common is, and maybe makes us a little different from some other doctors, is we're much more comfortable in a team. We're at home in a team. We rarely work alone. We're always working with our partners because we can't do all of that ourselves. We can't know everything, and we can't do everything. So we work together with other healthcare professionals, including many of whom are also specially trained in geriatrics in their own fields, to do these assessments and do these multi-component, multifactorial, comprehensive interventions. So an example of a team that I work with when I take care of people at the VA hospital, or that Dr. Tang works with when she sees people in her pre-hospital clinic, it's not just the doctor, but social workers, physical and occupational therapists, pharmacists, often specialized geriatric pharmacists, nurses, and other healthcare professionals, all working together. We do best as a team, and we know that we give the best care for older adults as a team. Now this is great if you're coming into a well-outfitted, state-of-the-art geriatric clinic. Who's been to one of those? They do exist. We have one down in San Francisco. There are others scattered around the Bay Area. But again, not enough geriatricians. So how do you think about this? Well, the same principle really applies to everything that's affecting your health. You need a team. Older adults, especially those with complicated problems who maybe need some help day to day with things, but really everyone needs a team to succeed. So who might your team be? Not saying you should go out and hire your social worker and a physical therapist. If you can, that's great. But think about all of the things that go into taking care of yourself day to day and giving you the best shot at staying independent and staying healthy, and what sort of things that you need help with to make that happen. And it's different for every person. But for example, everyone should have someone who can come with them to a doctor and help them keep track of what happened. Someone to take notes, and someone to ask questions, and someone to be their external hard drive, so to speak. Everyone should have an advocate, someone who would go with you if you wound up going to the emergency room, and make sure that they're looking after you the way that you want to be looked after. It's really hard to do that yourself when you're in the patient role. We all need someone at our side to be our advocate. So who's your advocate? Who's your shoulder to lean on? Who's your handy person if you need a little bit of help with mowing the lawn or doing some carpentry? Who's that person who will help you stay in your house doing your own thing? Maybe you're taking care of a loved one who has dementia, and you need help every once in a while looking after that person while you go to your own doctor's visits, while you go off and do the things you need to do. Who's that part of your team? So we all can put together our team to help us take care of the things that we need to take care of to keep us healthy and independent and functional. So it's never just one thing. There's always lots of things going on, and the art and the science is parsing through all that and taking a systematic, comprehensive approach to treat these complicated problems, and doing it as part of a team. So one example I mentioned very briefly is the things that can contribute to a fall. Well, maybe that medication is making that person a little bit dizzy, or maybe they're taking a water pill that's having them to get up really quickly to get to the bathroom. So medications are a really good thing. Used the right way, lots of medicines will help to save your life, will help to keep you healthy, will help to prevent the sort of bad things that would affect your independence and affect your life. But medications have a downside too. So here's an example of what we call a prescribing cascade. Let's say you go and see your doctor and you have a little bit of high blood pressure, and your doctor's a good doctor, and he knows that treating blood pressure will reduce your chance of a stroke. And that will help not having a stroke, will help you stay independent. So that's a good goal, and he wants to treat your blood pressure. So you prescribe some amlodipine. The next visit, though, the patient has some leg swelling now. Well, maybe that's a little heart failure. Maybe that's new. Let's give them a water pill and get that swelling down. Next visit, well, now they're suddenly having some incontinence. They've never had that before. This is new, but there's a medicine for that. Let's give them some oxybutynin and treat their bladder. The next visit, now they're a little confused. They had a fall at home, and they're not remembering things so well. Do they have dementia? And all of a sudden, in a couple of months, boy, Dad's not doing so well. What's going on? And all of this can be traced, all of this is from the medicines, from the oxybutynin making someone confused, from the furosemide causing the incontinence, from the amlodipine causing the leg swelling. And you really need to go all the way back here and try to stop what's causing the problems rather than adding on something new for everything that comes up. So this is an example of polypharmacy. Polypharmacy, too many medicines. And that's really all it means. When you're taking so many medicines that they're starting to do more harm than good. Or at least some of them are starting to do more harm than good. So too much of medicines are good, but too much of anything can be a bad thing. Too much water. We all need water to survive, but as we've unfortunately seen in the last couple of months, too much water flooding your homes and your cities is a terrible, terrible thing. So too much of anything can harm. It's very easy to be taking too many medicines because medicines are easy to prescribe. You feel like you're doing something, you're helping. The person has a problem, you want to fix it. I have a medicine for that. It's very easy to prescribe lots of medicines. It's much harder to stop taking medicines than to start them. When's the last time that anyone had a doctor ask them, I wonder if we can stop this? As Dr. Tang talked about, many well-meaning doctors want to treat to the guidelines. But if you treat to the guidelines for everything that a person has, you wind up with this laundry list of medicines, and we don't really know if they're all working the way that we think they are. And many of us are prescribed medicines from multiple doctors, doctors who don't always know what each other are doing, which is a big problem. And maybe they're prescribing different medicines for the same thing. So it's really easy to have too many medicines. And the thing is, once you get to a certain point, adding more medicines makes it more likely that you're adding medicines that aren't really helping and maybe harming. And it makes it less likely that you're missing out on something. So as you add more and more medicines, it's really not much more likely that you're adding medicines that are helpful or you're missing medicines that you should be taking. But as you add more and more medicines, you tend to add more and more medicines that you don't really need, that may be inappropriate. I like to think about things in visual ways. I'm kind of a visual learner. So the way I like to graph things out. So here's a graph of what the good thing we're trying to do and the number of medicines we're taking. And the key take-home point is that the first medicine you take for blood pressure, the first medicine you take for diabetes, is probably really helping you a lot. It's probably helping to prevent strokes, helping to prevent kidney problems from the diabetes. It's having a big impact on your life. The second medicine has a little bit less of an impact, but maybe still good if you need it. The third, fourth, fifth, sixth, seventh medicines are probably not adding anything at all. So each additional medicine adds less benefit, diminishing returns. But each additional medicine increases the risk of harms more and more. There's more opportunities for interaction. There's more opportunities for causing side effects from interactions with the way your body is aging. So more and more medicines doesn't necessarily mean more benefit, usually it doesn't, but often it means more risk of harm. So the trick is working out how to keep yourself in this Goldilocks zone, where you're getting the most out of your medicines, but you're not tipping over to that point where you're doing more harm than good. Treating most diseases in older adults follows kind of the same pattern. You do want to treat problems. We certainly want to treat blood pressure, for example. We know that helps save lives. But if we go too far in the other direction, we wind up causing harm too. So not too much treatment, not too little treatment either, but to find somewhere in the middle. A lot of the cutting edge of large randomized trials in geriatrics has to do with figuring out exactly where that middle is, exactly what is too much, what is too little, so that we can guide our patients to be in the just right zone. So for the example of blood pressure, we know very well we want to treat blood pressure because we know from large randomized trials it prevents strokes, prevents heart attacks, and saves lives. But if you treat blood pressure too much, you can also harm people's and actually increase their risk of dying. So blood pressure always shows this kind of U-shaped curve where there's a flat spot in the middle where people are doing the best, but if you go too high or if you go too low, you increase your risk of dying. In this case, it's from strokes and heart attacks. If your blood pressure is too low, it's probably from things like, well, it's still from strokes and heart attacks and falls, but for example, strokes because your brain just can't get enough blood because the blood pressure is too low. So too high is bad, too low is bad. You want to find the middle. Now, one of the tricks of this is that as you're aging, your body is changing. So what was the happy, perfect middle for you, the perfect dose 10 or 20 years ago, may not still be. And there are some good biological reasons for this. And they happen to all of us. These are not diseases. These are changes that happen to all of us. Our kidneys gradually lose function. Your kidneys decline a little bit, and so drugs that are cleared through or excreted through the kidneys, the dose may have to change as you get older. You have to be very careful about kidney function. And all of our bodies are changing. No matter how fit you are, even Jack LaLanne gradually lost muscle as he got older and gradually accumulated a little more adipose tissue. So some drugs are water soluble and they stay in your muscle. Some drugs are fat soluble and they stay in your lipid. So as your body composition changes, the dose that you need to keep the right level in your body changes too. So even if nothing else is changing, your body is changing too, and your medicines and other treatments may need to be adjusted to meet that. And the other thing to keep in mind is that side effects are often more commonly felt in older people. It's not necessarily that they happen more often. A drug may have a similar effect in young people and old people. But think about that fall. If a young person is taking a drug that makes them a little bit dizzy, they're going to feel a little bit dizzy. Maybe they'll stand up a bit slower. Maybe they'll stand up and, oh, I'm a little bit dizzy. But they're not going to fall. But for an older person who maybe already has a little bit of mobility problems, who maybe uses a cane, who's maybe a little bit unsteady, who's not as strong, that little bit of dizziness, that same amount of dizziness, could be kind of the last straw that turns into a fall. So older adults are more likely to suffer harms or to really feel the effects of a side effect. Because of both changes from aging and because of other diseases that they have. So the take-home points are that more medicines are not necessarily better, and often when it comes to medicines, less is more. Medicines help, but make sure you're taking the right medicines. And that a new symptom in an older adult is a medication side effect until proven otherwise. One of the first geriatricians I met in fellowship said this as a mantra to everyone that we saw. It doesn't mean that everything is a medication side effect. New problems, new diseases do happen. But whenever something new comes up, the first thought should always be, is this a medication side effect? And I want to be careful not to get into this prescribing cascade where I'm throwing one thing after another and just make things worse.
So I think one thing that I want to add to Dr. Newman's piece is that if anybody here is on an anxiolytic medication, so Xanax, lorazepam, these medications are a good example of our body composition changing and that dose actually having a different effect on our body than it did many, many years ago. So I would highly encourage those that are on that medication to make sure to talk to your doctor about that dosage. It's a medication that can cause delirium or acute confusion or potentially put you at higher risk for falls in the middle of the night or so on and so forth. So I just wanted to put that in there. So the last concept that we'll cover is important conversations. And what are these important conversations that we are to have? Okay, great. So it's advanced care planning, and I know in the glossary terms it's listed there for you, but basically what advanced care planning is a process in which we, older adults, even teenagers can go through to elicit the goals and values that are important to us. These are the things of we get up in the morning for what reason? What are the things that drive us? And using that to help tailor our medical care to achieve that goal. One thing that I was sharing with Chris earlier is Senator McCain, I don't know if anybody saw 60 Minutes this past Sunday, but he was interviewed and they're like, how are you doing chemo, radiation every day in the morning and then going to do your job, And he said, I'm very thankful for the amount of years that I've lived. I'm thankful for my life, but my mission is to serve my country, and that's what I get up every morning for. And so I would highly encourage, advanced care planning isn't about end of life, decision. I think it's important to know advanced care planning and to use that for that discussion, but just to say, don't be, turned off by having these conversations because, that means that I'm going to die or, something like that, okay? The other point I wanted to say about this is that advanced directive, which is also defined in your glossary terms, is basically a legal document in which we fill out to say, this is the person that will make decisions for me if I'm not able to. And then it can also say exactly what these decisions should be, and a lot of times it goes into if I were to have a heart attack or, have a sudden cardiac kind of event, do I want to be resuscitated? So it's within the domain of advanced care planning, but advanced care planning is much more than that. And my husband made me do my advanced directive and advanced care planning before he would marry me. and he's in tech. So okay, let's see. Which button do I push? Yeah. Okay, great. So I just want to do a little advertisement. This is definitely free, but so helpful. I tell all my patients in my clinic to do this. This is the Prepare website, which is www.prepareforyourcare.org. And I believe there's going to be a handout outside on this. But basically, this is an interactive website. It's free, and it has videos of people actually going through the advanced care planning process that you can watch. And then you can also also reflect on and answer for yourself. And so here are the 5 steps that they recommend. First one is choosing a medical decision maker. What I would say is you got to pick someone that you know will represent your values and your goals, and will do what you want them to do. Step 2, decide what matters most in life, and that's your values and goals piece. Step 3, choose flexibility for your decision maker. That's basically, they need to follow to the T what you've put on paper, or, given the circumstances, the decision maker knows what I want, they can make full decision. Step 4, tell others about your medical wish. And I would say that's very important. That's one thing that we feel uncomfortable talking about with our loved ones. They're like, oh, Mom, I don't want to talk about this. You're never going to die, or you're never going to have issues, right? And so it's bad when you avoid these topics and something acute happens, nobody's prepared. So I would highly encourage this. And the last piece, and we'll go into a little bit more, is ask doctors the right questions. All right, so how to talk to your doctor. So this is your health. You need to drive the agenda. What is your agenda? So these are the questions that I would recommend asking, and I believe this is also part of the handout outside. So you say, this is what matters most to me. Whether it be, I want to make sure I stay in my home, or I want to be able to not have to take 19 medications a day. It dries my mouth. I can't eat after that, What is the goal of what is being offered? Does it actually fit with what is important to me? So these first 2 questions are really driven by goals, which is our first concept, right, earlier that we talked about. This third question of, should we still be doing this? And how does this affect all the other things that I'm doing? That takes into account the complexity of the medical care, right? And so how do we think about the complexity within this larger domain? And then the last question of, is this the right care for me?
So some examples that we've talked about as we've gone through, for example, the lovely patient that Dr. Tang was helping to make a decision about surgery. And what was the goal of that surgery? It's not just he had a problem, we should have surgery to fix it, but that his goal was to have the best chance at staying the most active. And was surgery the right choice to give him the best chance to stay the most active and able to play with his grandkids? And I want to point out something else Dr. Tang said that you may have missed. When she was talking about the risks of that surgery, she didn't say you could die. Of course he could die. We all could die anytime. But she said you could wind up in a nursing home. And so for him, I know this is true for my grandmother too, and for many of us, there are things worse than death. It's not necessarily the fact we could die that worries us, but sometimes it's what might happen instead. So if his most important goal was to be as hale and hearty and strong as possible, play with his grandkids, well then maybe he wasn't so worried about dying as he was about losing that ability and having to depend on others and not being able to play with his grandkids and being in a nursing home. So what are you trying to avoid? It goes with your goals. What are you trying to achieve? Goes with your goals too. It's really all about thinking what's most important to you.
Right.
And do us a favor, don't tell your doctors you heard this stuff from us. Doctors have agendas too. Every time you walk into your doctor's office, they have an agenda, but remember, you have an agenda too. And it's okay to talk with them about, well, what should we address today, and what will we save until tomorrow? And usually the doctor doesn't get to everything they want to get to, and you may not get to everything you want to get to, but make sure you get to the important stuff. It's okay to have that bit of negotiation. And do it when you first walk in too. Don't wait until the last minute, as the doctor's hand is on the doorknob, as we say, and there's a doorknob moment. Oh, by the way, I fell yesterday. So do it up front. And doctors, doctors will get used to this. Many doctors like it,
Yeah.
but it's okay. You should be leading that conversation with your doctor.
I would say two other things, and thank you, Dr. Newman, for bringing that up. One is it takes multiple visits. It takes a relationship with your doctor. So don't feel like you have to get it right, one-time visit, this is what we're going to talk about, because these things take time. And as you age, as we all age, our goals change, right? And so this is a process, and that's okay to recognize that. And the second thing escapes me, but I will share it if I remember it. So just to recap on this last section of having important conversations is to identify your goals and values and share them. And I would recommend the Prepare website to help you do that. And then also ask your doctor how your care fits with these goals. And the second point I actually remembered just now. So I don't, there's all this fear about going into the nursing home, and I understand a lot of people are very uncomfortable leaving their home that they've lived in their whole life. I just want to make sure to say, I've seen patients become poster childs of nursing homes in which they were in isolation, and then they go into the nursing home and now they've got a whole support system.
Yeah.
So I want to make sure that I'm not saying that, nursing homes are bad or going there is a bad idea. It just really depends on what's important to the patient and what they're willing or not willing to do. So the concepts covered: individualizing care to the person, that's the goals discussion we talked about. Multi-pronged approach, which is the complexity piece, and that's geriatric syndromes that Dr. Newman talked about. And then advanced care planning are important conversations to have, not just with your doctor, but also with your family. And lastly, I want to encourage you to think about what actions will you take next as your own geriatrician? Is it to approach your doctor and say, hey, do I need all these medications? Can we go through them? Or to think about, what are my goals? What's important to me? Or is it, I know my goals, I'm going to talk to my family member about it so that they're not out in the dark when something acute happens. So we want to thank the Dr. Levy family, as well as UCSF and Buck, but especially I think our patients and their loved ones for taking such good care of them, as well as our community, and you guys for coming and just being engaged and interested in living longer, better lives. So thank you. Great.
So now it's your turn to get involved. Those of you who have questions, hold up your cards. Our volunteers will pick them up and bring them to me. Because I'm here, I get to ask the first question. I want both of you to, can you talk about one of the syndromes that you put up there, delirium? When we were first talking about this event, you guys mentioned it. I'd never heard of it. What is it, and how does one avoid it?
So
I think that's a whole topic in itself.
Briefly.
Well, we should say first that we've spent years training in geriatric medicine, and this is just scratching the surface. We're trying to kind of paint a picture of how we think about things using a couple of examples. But boy, there is so much that we could talk to you about, and so much that you've probably never heard of before. And we could spend hours and hours doing this, and I hope we'll have an opportunity to talk about other topics too. Delirium, I think, is one of the most important things that you've probably never heard of. Who's heard of delirium? All right, not bad. Maybe about a third of people.
I usually hear it on the radio as a good thing, though. Like, oh, excited with delirium. So it'll be good to hear what it is.
So delirium is a big problem that's very common in older adults when they get sick or in the hospital. It's an acute confusional state that's brought on by illness or by some sort of physiological stress. So often getting sick, but it can be brought on by heart problems, can be brought on by just the fact of being in a hospital or being in an intensive care unit. It's a confusion, so people might lose track of where they are. They have trouble paying attention to people. Their memory isn't good. They may even get paranoid. It's heartbreaking, but every once in a while, I'll be taking care of someone who develops a delirium from their illness. And they'll start accusing family members of stealing this or stealing that, and it's part of the delirium. It's acute, it comes on suddenly, and it's related to the illness. And it can be treated, and it can go away. But it can be very distressing when it happens. And it can, as you imagine, make it challenging to fix the problem that caused it in the first place, to fix the infection, or to treat the medical problem that brought someone into the hospital. But delirium is an example of a geriatric syndrome where there's always more than one cause. It's part the illness that's happening right now. It's part if the person has some cognitive impairment already or has dementia. It may be some medications. It may be some of the things that we do to people in the hospital that can exacerbate confusion. It's always more than one thing. And the way we treat it is with this systematic, comprehensive approach involving different disciplines in the hospital. And we can treat it. It's an example of a terrible problem, a terrible geriatric syndrome that we can prevent about half of by doing care in the right way in the hospital. And none of that involves giving drugs. It's all about treating the problem that caused it, not doing things that might make it worse, and in trying to arrange the whole way you provide care to that person to avoid exacerbating it. So all non-pharmacological approaches that can prevent half of delirium and might be implemented in the setting of a geriatric care unit in a hospital, which many hospitals are developing these days. But probably the most important thing that many of you have never heard of, unless you've had the misfortune of experiencing it through a friend or a family member.
So I'd like to add two things. One is it's easier to prevent delirium than to treat it. Once you get delirium, yes, you can treat it, and most of the time it'll clear, but it takes time to clear. And so I would say as geriatricians, we are taught it is very important to prevent it. And one of our goals, one of my missions is to try and change the healthcare system so that we put in place the things to prevent delirium just up front, making sure that the patient is aware of the sleep-wake cycle, making sure that the blinds these are all very easy to implement things. We just need to do it as a healthcare system to help prevent delirium in the hospital. The second thing is I do counseling in the pre-op clinic for my older adults and their loved ones as to how they can help prevent delirium. So whether it is to make sure that they get their hearing checked and their visions checked prior to surgery so that they can have all their senses intact so that they're not at risk for delirium prior to surgery. So the key that I would say is it's preventable. Not all of it is preventable, but we need to do what we can to avoid delirium because it's hard to treat. Treatable, but
We have great questions. We have questions
Great.
that could go for hours and really. So
Thank you,
how
guys.
does cancer treatment fit into complicated geriatric care?
How does cancer treatment? So I think you can think about it in terms of goals, right? And you can think about it in terms of just like Mr. D's example of surgery. So cancer treatment looks very different for different people, and side effects for different medications or chemo treatments are different. And so not to get too specific, but really thinking about saying to your oncologist and your primary care doctor or your the radiation oncologist, this is what's most important to me at all cost. I do not want this thing to be impacted by my cancer care. Yeah, I hope that helps. If not, please come up later.
I think the key is, again, thinking about the big picture goals and how different cancer treatments fit into those goals. And that depends on the individual person. What is most important to them? What do they want the best chance of either achieving or of not losing? And then designing the approach to the cancer to try to meet those goals. And that will look different for different people. Now, on the other hand, it's, we talk about evidence-based medicine and randomized trials, and randomized trials tend to be very systematized and formulaic. So we know that this combination, does this when you test it in a trial. And you always want to be mindful that if it can be difficult to tweak things. You're never quite sure what's going to happen if you tweak things, but still, you and your doctors can work together to figure out how to customize, how to start with a plan and then customize it to fit your needs. And that'll be different for different people. The key thing is just to keep in mind, there's a big picture here. It's not necessarily just, I want to eradicate this cancer. It's that, I want to treat this cancer so that I can, or so that this will happen. It's a means to an end.
I would also say that there is work being done, I know at least at UCSF, with our oncologist, working on looking at the aging population in cancer, because a lot of these trials are done in younger folks, right? Yeah. Like drug trials a lot of times are done in younger folks because they don't want the complexity of the older adult looking different from the other older adult and their side effects messing up their trial. And so thankfully there are oncologists that are interested in this field, and so they're trying to advance that.
Every once in a while, geriatric medicine is a subspecialty. We don't have subspecialties, but every once in a while you'll meet a geriatric oncologist, someone who's actually done specialty training in geriatrics as well as in oncology. There's a few geriatric cardiologists out there, so every once in a while you'll meet these kind of dual individuals, and they're wonderful if you can find them. And I would try to seek them out because they're especially good at figuring out how to apply this knowledge and these principles to the actual person sitting in front of them in the office.
So we got a number of questions about falls and balance. So what's the best practice for balance for myself and everybody in this room? If you were going to give advice on how to stay steady as we grow older, what would you say?
Yeah. I guess the quick answer is, like many things, it's use it or lose it, or at least lose it more quickly. But one of the research paper of the decade in geriatrics, I think it was voted from the Journal of the American Geriatric Society, was a randomized controlled trial of the effects of Tai Chi on balance and falls, which is not an endorsement for Tai Chi specifically, but it was a really cool and fun example of how an exercise training program that's focused on balance and focused on core strength can help prevent falls. And I think there's really good data from randomized trials to support that. In general, exercise really is a tonic for a lot of things as people get older. And how much exercise? The answer is always a little more than you're doing now. How active should you be? A little more active than you are now. The kind of exercise, there is no like one weird trick or one perfect exercise you should do, but there are kind of different sorts of exercise that are probably better for some problems than others, like cardiopulmonary kind of endurance exercise, trying to build up your endurance, get your heart rate up a bit and breathing a little heavy. That's probably really good for heart problems and for building your endurance and for maybe even helping keep your brain healthy. Core strength and balance oriented exercise like Tai Chi is better for helping to prevent falls. If you have had a fall, though, these things are one component of this sort of multi-component, multidisciplinary approach that can help to identify what are all the different triggers and contributors, and while you're exercising, which will definitely help, what else can we do to help reduce the risk of you falling? So it's one part of the whole.
So yeah, the things I would add is gotta try and maximize all sensories that you can. So vision needs to be good, your hearing is good, just do what you can is what I say, and if you can't help it, that's okay, leave that be, focus on the things that you can. And I would say I see some of my patients actually don't want to use their cane, or they don't want to use their walker. But if they're at a risk of falling, it may be better to do those things and to think about, well, how can I change my mindset about using this assistive device? Or whether it be, in my home, I can get some railings put up to avoid, potentially falling. I can grab onto something. So as Dr. Newman said earlier, this is a pronged approach. It's always good to kind of try and cover all your bases. But I would really, exercise Tai Chi. It's good stuff.
We talk a lot about mobility and about moving. No matter where we take care of people, we're always talking about mobility, especially in the hospital, where we know very well just the kinds of problems that lying in bed for a week can cause a person. So that's the other point I'd make too. The best way to prevent falling is not to not get up. It's not to not move, but it's to move more and to become more fit. And that's especially important in a setting like the hospital, where you really want to make sure you're not losing strength, but that you're getting up and moving and keeping yourself as fit as you can.
And as a loved one, I'm sorry, Chris, I know you're saying, as a loved one caring for an older adult in the hospital, for good intentions, the healthcare system or the hospital might say, please stay in bed, you're ill, you're not feeling well. But as Dr. Newman said, you don't use it, you lose it. And so if you could help, just encourage the movements, make it easy for, your loved one that's sick to get up and go to the bathroom to brush their teeth, because that's one thing that I worry about in the hospital for my patients.
A number of questions about social isolation and the importance of community as we become older adults.
Yeah, that's definitely up my alley. I'm actually putting in a grant looking at psychosocial factors associated with surgical outcomes. I think social isolation is an issue. Obviously, all of you that are here are somehow connected to a community or are interested in being part of a community. And I would highly encourage, the older we get, the more we need friends, the more we need help with, and just this sense of belonging is so important. There has been research to show that it actually affects mortality outcomes. And so if you feel lonely, your likelihood of living longer or even, being happy is less likely, right? So how to engage, join the Buck community. That's a good one. I don't work for the Buck, by the way. But to say just any sort of activity, just go in there. I challenge you guys to do that. Yeah.
So there's a kind of a two-part question here. There's somebody who says, my doctor says I'm pre-diabetic. Is this reversible, or is it just a question of time? And my follow-up question is I always had this preconception of geriatrics and geriatricians that all that you do is sort of help somebody maintain and hopefully not get worse. So when somebody has some of those geriatric syndromes or is pre-diabetic, can they get better, or is it just a question of trying to maintain as long as you can?
Those are great questions. I'll start with around the pre-diabetes idea and then get into this, can we actually get better? So there's, our bodies change as we age, and there's often a lot of debate even among doctors about, well, what's normal and what's a disease? Often the differentiating factor is there a drug that a pharmaceutical company sells for that particular condition? If so, it's a disease. If not, it's normal. I say that with a little bit of jest, but there's some truth to it. So there's some debate about what this pre-diabetes thing is. Narrowly, it's a question that actually has been looked at in randomized trials, that if it looks like your blood sugars are rising and might be on the way to diabetes, can you prevent that? And the trials show that taking the most common diabetes drug, metformin, can prevent some of those people from going on to having full-blown diabetes. It also showed, though, that metformin is not nearly as good as exercising. Especially, actually, in older people, exercise was much better than metformin. So are these conditions diseases that we should be treating? If we're trying to prevent them, what's the best way to do that? Are often hot topics of research. And about, well, is the best that we can hope for to just stay the way that we are today? Often, that'd be a pretty good thing. If I'm not sure I am getting up from chairs as quickly as Mr. Levy's brother did this morning, if he can stay just the way he is today, I imagine he'd be, I don't want to speak for you, but you'd be doing pretty well. But for others of us, maybe there's things that we'd like to change. And the nice thing about these comprehensive approaches to complex problems is that they can fix things. These complex problems, remember, are not the result of flipping a switch. Things like incontinence, for example, or falls. They're the result of many things that have happened, probably over a period of time, and that you eventually get to the point where it causes the problem like incontinence. But if you can fix just the right things, kind of turn the dial back just a bit in a couple of different domains, you can get yourself back over that threshold where the incontinence is not happening anymore. Because maybe you've adjusted the medication regimen so that you take your water pills in the morning instead of right before you go to bed. And maybe you've cleared the path between the bed and the bathroom so that you're more readily able to quickly get to the bathroom. And maybe if you need a walker, you've positioned that walker near the bed. And maybe you've changed your blood pressure medicines when you take them, maybe, so that when you get up at night, you're not lightheaded. Or maybe you've changed, as simple as changing where the light switch is in the bedroom, so that you can quickly turn on the light switch and get to the bathroom more easily. But that's an example of you kind of work on a bunch of different things in different domains, and you can take a problem and fix it. Move yourself back over to the right side of the threshold where you're no longer having that syndrome or that problem.
Yeah, so the things I want to add, so I was laughing a little bit to myself. I was like, oh, I'm so glad that John's addressing this question first, because it irks me, this whole discussion of prediabetes, of osteopenia in an older adult. There's this concept, for better or worse, that's called time to benefit. So it's this concept that geriatricians have. We've got Dr. Saley, who's a prominent researcher in our group, looking at how long does it actually take for preventative care to actually make a difference in one's life. So diabetes is bad and scary because it can affect your vision, it can affect the way you feel things in your hands and your feet. But those are many, many years afterwards, after this diagnosis of, after many, many years of high blood sugars, right? And so if we're talking about, for example, my 79-year-old lady with 4 medical comorbidities, right? How long does she have to live? How long will she have to wait to see the benefit of treating diabetes or even thinking about pre-diabetes, right? How long is that? Is it worth it? And as Dr. Newman showed earlier, the more medications you take, right? Like you have harms, things like that, but also worrying about other medical diseases may take you away from actually addressing the ones that are most important to you right now. And so I think this concept of prediabetes, while it may be important for that 14-year-old kid, it may not be important for my frail older adults that may not have 50, 60, 70 years to live, right? So this concept of time to benefit is really important.
What's the goal of treating these effects of aging or pre-disease states? What's the goal? That's the key.
Yeah, I think if diabetes is affecting your life in terms of you're having to get up to urinate a ton because your sugars are high, or if you're having kidney issues, like of course that's something important because it may affect your overall function and for you to be able to reach whatever goal you want. And I think one other thing that's important to point out is Dr. Lee is on the American Diabetes Association panel or some important thing, and they're actually working to change the criteria for diabetes in our older adults with this time to benefit concept in mind. So the 7.0 that we strive for, the 6.5, may look different for older adults. So that pre-diabetes may not even be an appropriate diagnosis for whoever asked the question.
So we had a question about problems with over-the-counter medications. Are there problems with them? And also, you mentioned a couple drugs, Dr. Tang. For both of you, are there drugs that are red flags for older adults? But talk about over-the-counter meds.
Oh, yeah. So one medication that I advise my patients to really look hard at and think about is those Tylenol PMs.
Yeah.
The medications that have Benadryl in it. Benadryl can cause can actually increase your risk of delirium, confusion, even in your own home. And so Benadryl is hidden in these medications like Tylenol PM or Sudafed PM, or not Sudafed PM, but like some other sort of medication with a PM on it. So I would say that's important. And then thinking about all the vitamins that you take, right, that you spend money on that may or may not affect your, well-being. That increases your pill burden. And so if you spend your money and your time and your effort taking these medications, it may take you away from actually taking the medications that have greater impact in your health and in your life. So those are 2 points that I wanted to bring up.
Yeah, I think it's important to remember that, so hey, I can buy it at Target, it must be safe, right? These are drugs too. Everything you buy over the counter, and even these vitamins and minerals and supplements, these are drugs too. And you should think of them the same way you think about the drugs that you get from the pharmacy with a prescription from your doctor. So when you talk to your doctors about this is a list of everything I'm taking, all of that stuff should be on it too. It's really, really important. They're all the same. Just because they're over the counter doesn't mean they're not drugs. And yeah, actually, older people do need to be especially cautious about some of them. Medicines containing Benadryl is a great example. And actually, in the olden days, we're much smarter about this now. But in the olden days, Benadryl was a common reason for delirium in older adults. Suddenly grandma's kind of loopy and not the same today, and often that can be, remember, everything is a medication side effect until proven otherwise. That could go back to the diphenhydramine. But even things like some pain medicines, like the non-steroidal pain medicines, can have side effects that are more likely to be a problem in older adults, like their effect on kidneys or their effect on the heart. So it's important to remember these are all drugs, and your doctors, whoever's in charge of prescribing your medicine, should know about all of them. Now, some medications need a little more caution than others, which is not to say that they should never be used, but it's to say that one should be thoughtful if you're going to use them. Wouldn't it be helpful if a bunch of geriatricians got together and made a website that has a list of these medicines that you should be a little more cautious with? So you can go to it. I think we may have a handout to give you.
We actually, one of our handouts today includes information about drugs that you need to be wary of.
Yeah, so there's a constantly updated list called the Beers criteria. It's not drugs that go well with beer, but it's in honor of a geriatrician named Dr. Beers, who was kind of in the forefront of helping us to learn about how to use medications differently in older adults, or what are the different needs of older adults. And so every few years they update this list, and you can find it on the website of the American Geriatric Society, or their Health and Aging website, and you'll have handouts with this. And you can look up and see, are any of the medicines that I'm taking on this list? And again, it's not to say that you shouldn't panic if one of them is. These are not medicines that you should avoid at all costs or that will kill you, but they're just medicines that should be a little more thoughtful about, is it really the right medicine? And maybe it is. I'll give you an example, actually. So one of my favorite patients I took care of for several years at the VA was on a medicine. I was prescribing him a medicine that was on the Beers list. I felt like, was I a bad geriatrician? Well, he was a former paratrooper. I met him when he was in his early 80s. And he had terrible arthritis, probably in part from his paratrooper days, I can only imagine. But it was, if he didn't take a certain kind of anti-inflammatory pain medicine, he had a really hard time walking around and doing his day-to-day thing. So we figured out that he needed to be on this particular anti-inflammatory medicine in order to do the things he wanted to be able to do to stay healthy and active. And it happened that was on the Beers list, and we were just careful about watching for side effects, but it was the right thing for him. And he celebrated his 80th birthday by going to I think Norway, somewhere in Scandinavia, and jumping off a tower and parachuting. So it worked for him.
Wow.
But these are medicines you want to be more careful with.
So we're almost out of time. A lot of people asked, how do you find a geriatrician? I mean, I'm assuming you guys have other things that you do, so you're not the only two that are available to us. How do you find somebody if you really are at that point where you need that care?
That's a really good question. So we're not snoozing and we're not hiding. We're definitely trying to help the healthcare system along and our nation along in making it safe for all older adults, even without geriatricians as part of their system. So I just want to say that piece. Logistics-wise, how do you find one? So UCSF has quite a few of them. I would say it's a challenge to get into the Institute on Aging, right? That's the IOA on Geary Boulevard. So I would just hammer call them. I don't know if anybody has any sort of tricks. I try to get a patient in, and it's like, you have no sway, despite being a geriatrician in our division.
You're more likely to find geriatricians. So again, we're kind of unusual doctors. We're not really good at making money. We're really bad at making money. We're particularly good about actually making other people less money.
Yeah.
So that's one of the reasons why we're not so popular. But it means that a good place to find us are in integrated healthcare systems where they're trying to where they have a kind of head-to-toe system where they take care of people whatever they need. So systems like a big academic medical center like UCSF, or systems like Kaiser, or systems like the VA. These are actually places where geriatricians tend to congregate because suddenly we're popular because we're making other people less money by keeping people healthier and out of the hospital, where they're not making other people money, but all else being equal, most of us would rather stay out of the hospital and not make doctors make money. So you can ask if you're like a Kaiser member, or if you're at UCSF, you can ask. We have outpatient clinics at UCSF. We even do house calls. These are crowded programs, but you can ask. You can call and refer your loved one.
Yeah.
I wish there were more of us. Locally, the Over 60 clinic at Berkeley has some geriatricians on staff, and you can look for. If you have a health insurance plan that has a website you can search, for example, you can look for geriatric medicine specialists and see who comes up. But if you look hard enough, you can find us, but there's just not too many of us to go around.
That's great. So before we wrap up, I just want to say that These two folks, generous folks, are going to be around for a few minutes afterwards that you can talk to them. Dr. Tang needs to leave at 12:30 because she has to get to an appointment in San Francisco, so you may see me strong-arming her away from you. Please forgive me. There were questions that were asked about the Buck Institute and our programs. I purposely ignored them. You can talk to me. You can talk to Eric afterwards. Also, there were some questions about John's research on nutrition, so you could probably talk to him afterwards. So I want to thank you for coming. I really want to thank our speakers for being here today. Please consider becoming a member. If you're not a member, please donate to our very good work. We really do appreciate your support. Thank you for coming.
Thank you, everybody.